A very warm welcome to everyone. Thank you for joining this educational webinar. We're very lucky and very fortunate to have so many of you join us today from very many different parts of the world. So we thank you for that. Just a quick introduction. My name is Victor Deer. I'm the Senior Clinical International Trainer here at Neolight, and I'm going to be hosting today's webinar. Today's webinar is brought to you by Neolight and the Clinical Education team and our CARES program, which supports the effective use of our products through educational support and shared best practice. Now, CARES stands for Continuing Advancements and Resources in Education Support. Now, lots of our products, as well as the relevant therapy areas, the information can be found on our website. And if you go to the education part at theneolight.com, you'll be able to find all that information on there. Now, we're always updating that the resources, the information that you'll see on there, so please check back regularly. Now, today's webinar, I'm very excited to be talking about this, is the topic of nurse-led ROP, retinopathy of prematurity screening. And we've got an amazing panel of experts who are going to be sharing their insights with you today. So, but before we get started, a little bit of housekeeping. We're going to keep the cameras and the microphones on mute. Cameras are turned off, just to avoid any unnecessary distractions. Feel free to submit any questions during the presentations in the chat section. And what we'll do is we'll address those questions at the end of the webinar so that we're not disturbing anyone during their presentations. We plan to get through as many of those questions at the end as we can, but if we don't, we will then answer those questions directly. So we'll provide those contact details for you at the end of the webinar, so you can contact the clinical education team at Neolight, and we'll do our best to answer those questions directly. Now, before I do the introductions, and I'm very excited to do that, is what we're going to do is we're going to turn off the cameras, and then we'll just focus on the slides which are being presented and the information that's being shared with you today. So before we do that, let me do a quick introduction of Candice White. So Candice is a senior clinical specialist. That's Candice over there, with over 20 years of experience in ophthalmology and advocating healthcare education. Candice's passion has always been education, exploring opportunities in the NICU and ophthalmic communities to broaden access to clear, digestible learning material and content. And I know that Candice really is kind of an exponent of promoting that collaboration between several specialities, which I know that leads to kind of better advancements of patient care. So with that in mind, I'm very pleased to hand over to Candice.
Thank you so much, Vic. I'm super excited to present information, so I'm going to share my screen and we'll get started with the presentation. So as Vic mentioned, my background is very heavily ophthalmology. I come from lots of eyes. And when I started, I really wanted to find a way to say, how do we teach a group of people that may not have a lot of information about the eye? How do we teach them to be the best imagers that they can be? So I'm so excited to talk about the ICON today, about how we can image, the best practices. What are we looking at in the back of the eye? And what do we say when we think an image is good or quality? What kind of pictures are we looking at? So today's presentation is really going to be driven towards retinopathy of prematurity. There's lots of different things that we can image for and that we do image for with these camera systems. But today I really want to stay focused on nurse-led imaging in the NICU and why do we look for retinopathy of prematurity. And what we're trying to do is we're trying to look at photographic documentation to say, is there presence or absence of disease? And how far does that disease extend? May it affect long-term vision? Are we looking at something that's very treatable or something that we need to just watch over time? So we look at how the retina is vascularized, and you can see a little bit of vascularization, big fancy words where we've got a lot of blood vessels growing in places that they shouldn't be. Is it bad enough that we want to intervene, or do we just want to watch these vessels and see if they start to react the way that they should be reacting? So moving on, we're going to look at just pretty basics of what the eye is, what are the parts of the eye, and what do we see in images. So when I say basics, I know there's a lot of things that are up here, but I really want to say how do we make this digestible for those people who don't necessarily know what the vitreous is, what the cornea is. So the cornea is the very front window to the eye. It actually has a power, so it refracts light, and so does the lens inside the eye. So both of these subjects refract light in different areas, and that's kind of what gives us our vision to a certain extent. What's really important, especially with contact imaging for neonates and pediatrics, is we float the camera on the top of this surface, on top of the cornea. Understandably, though, for infants that are born early, a lot of these parts of the eye aren't done growing yet. That's really why we're looking inside the eyes, because we have premature birth. Things aren't progressing the way that they should be, so we want to document what that looks like. That being said, the cornea is not done growing yet. So we have to understand when we're looking through these parts of the eye, what are going to affect what I'm seeing, whether I'm standing at the bedside or whether I'm taking a picture with a camera. We float that camera in gel and we go through the pupil. The pupil is the center or the hole that's inside the iris, the colored part of our eye. It's not anything tangible. It's not anatomically something that I can touch or take out. It's really just an absence inside the iris, that colored part of the eye. And when we use dilating drops, what we do is we contract the iris. It's a muscle, and we flex it. That way it can't react to light. So I get it really in a mode where it's flexed. And when I look inside the eye, it's not going to move. It's not going to actually get bigger or smaller. It's going to stay in one fixed position. And that allows me to push light through that cornea, through the pupil, through the lens, all the way back through this vitreous jelly, which is just the substance in the middle of the eye, so that I can see the retina. The retina, I have always described like film in a camera. I know we are so far past anyone actually having film in a camera, but I still like to think about it in that way, in that it develops pictures. I'm taking a picture. That's truly what my eyes are doing. And then I send that picture through the optic nerve, and the optic nerve develops my photo for me. So if the retina is damaged, if the film in my camera is damaged, then you can imagine the picture that the optic nerve will take is also going to be damaged. And that's why we keep a really close eye on the retina. The macula really isn't something that we always see in pictures, but I always like to point it out. That's where so much of our central vision comes from. Our really, really good vision comes from just this small area, which is why it's so important. That's why we watch really this specific area. The other term that we hear sometimes in terms of ROP imaging is the ora serrata. And again, this is a pretty fancy word for where the back of the eye, where the retina starts to meet the structures at the front of the eye. This is where the retina is done growing. And the reason we talk about that sometimes is we want to say how far are we getting vascularized in to the retina. So let's look at a real picture. This is just a cut of what the eye looks like. So what am I really going to see when I'm taking pictures? And we actually don't see a lot of those structures. It's important to understand how they work and how they affect us when we image, but this is what we see when we take pictures. We see the optic nerve. It may always be a little bit of a different color. Everyone's got a little bit of a different shape, but typically it's the circular shape. It's a white or lighter color, and you can see all the vessels plug into this optic nerve. As I mentioned earlier, the macula is a little bit difficult to pinpoint, just in perfect pinpoint. But it's usually in the same spot from the optic nerve, sometimes a little bit darker in color because we think it has a lot of cells, a lot of rods and cones. If we remember learning about that in school, all of those are condensed in this one small area. Another item that's really important to look at is what I call the arcades. Sometimes we refer to them as the temporal arcades. And the reason this is important for imaging is it tells us where in the eye we're looking. So the optic nerve and the way that these vessels extend from the optic nerve tell me this is actually a left eye. You'll notice that the vessels on the other side of the optic nerve are a little bit straighter. They don't arc like an arcade. So that's how I tell, okay, I'm looking centrally, I'm looking straight up and down into the eye. And if I were to move this optic nerve, if I pointed my camera and it moved a little bit towards the bottom of this photo, that's what helps us understand how we're imaging in different quadrants. So in this animation, what we're really talking about is how do I tilt the camera in different positions to image different parts of the retina. We're really just pointing light into different areas and we're capturing what that looks like. And here's an example of what we say when we talk about quadrants. These are real life examples. I really wanted to bring to the table images that are taken on infants and neonates because that's really important. So this is what's called posterior pole, fancy for center. We're just looking straight up and down. I see my optic nerve here to the right, and then I see those arcades extending off. As I mentioned earlier, if I pull that optic nerve or I tilt the camera so that my optic nerve is at the bottom, what I'm actually doing is looking up superiorly. And you can kind of see when we tilt the camera, light is going up towards the forehead. Opposite from that, if I tilt the camera and my optic nerve is now in the top of my photo, what I'm really doing is I'm tilting and looking down towards the cheek. So I have an inferior view of the retina. Then by tilting the camera in different directions, I can also look temporally towards the ear and then nasally towards the nose. And this is how we build an exam looking for ROP in different areas of the retina. So I do want to take a moment. I know we don't have a lot of time and I could probably speak on this for days on end, but I want to talk a lot about quality. What do we mean when we say an image is quality? And the exact definition of quality is the standard of something as it measures against other things of similar kind. Sometimes what we're driven to do is compare imaging in neonates and adults to imaging, we compare imaging in neonates to imaging adults. And what I disagree with is that's not a standard that I can compare something because it's similar. Imaging on adults is not similar to imaging on neonates in any way. And these examples kind of show that. We have this wonderful young lady sitting at a tabletop. She's listening to instructions. We are guiding her verbally, and we can comfort her verbally. But I can't do those things in an infant or a baby. In this system here, we see a patient actually pressing up against a camera, so we're really using the ability to move them and guide them, both verbally and physically, to capture images in ways that we can't capture images in infants who are born too early, infants who are small. Neither one of these adults have a CPAP. They don't have any issues dilating. We don't have to put lid speculums in these patients. Again, because we have the ability to do so many things both verbally and physically that we can't do with small children and infants. So we have to rethink quality. We have to think, I have to shift from this mindset and not compare it to this mindset of imaging, where I'm actually making contact with the eye. And the reason that we have to make contact is because we can't verbally guide patients. I can't tell them to look up, look down. I have to do that for them. So let's look at some images, or actually let's look at how the eye grows, because that makes a big difference too in image quality. We know that when infants are born, the eye is obviously smaller than it will be in adults. So we think back to this imaging elderly patients, imaging even teenagers. The eye is going to be the same size every time we image. So my image quality is very reproducible. I'm always imaging the same kind of eye, the same type of eye over and over and over again. But with small ones, we have babies that are born premature, before term, and then we start doing serial exams. So we start our first exam around 30 to 31 weeks, and then we continue those exams weekly, and the eye is actually growing during those exams. So we will see our image quality change over time as the eye really finishes out the process that it should have done to begin with, but we had to halt that process. So I don't want to compare that quality image of the same eye, the same size, the same quality over time to an eye of a neonate or an infant that I know is changing. And this is an example of real life images on neonates, real life images of pediatrics. So I know compared to those adult images, they're a little bit hazier sometimes. Well, the reason is not because we are bad imagers or it's a bad system. It's because the eye itself wasn't done growing. We talked earlier about the cornea. The cornea is the first window to the eye, like a windshield. And if you can imagine your windshield's not clean, or if you bought a windshield before it had gone through all of its processes to be smooth and sanded down, then you would have a little bit of haze. Over exam times, we see that haze improving because the eye itself is growing and improving. We also may have areas of darkness to the side, and that's because neonates notably don't dilate great. Sometimes we have to put more than one set of dilating drops in infants and babies than we would ever have to put in adults because they're processing those drops differently, and we need the pupil to be as large as possible. We have wonderful instances like this picture where we get really, really good clarity, we have really, really good dilation, and a cooperative patient. But this image next to it, we look at it and think that it's not quality, but this is actually a wonderful image. It tells us so much about what's going on in the eye. If you remember, we're looking for presence or absence of disease, and I can see the blood vessels. I know what they're doing, and I know whether they're starting to raise the alarm for me or whether they're looking okay, and I can make choices for the next steps. Same thing in this image, an infant that didn't dilate very well, but I can still capture so much good information that tells me that these vessels are looking smooth, nothing super alarming right now, and I feel confident in saying I would love to see this patient in a week. So it's just redefining that thought process of what is quality. And understanding the basics of imaging. So we talked a little bit about the eye itself, how we put light into the eye, how it comes back to the camera sensor. But there are a few things that we can do to improve our image quality. One of those things is focus. So we can take a picture, and we definitely want to have our blood vessels in focus as much as possible. Remember, the cornea may be working against us. And this is not different in whether we're taking pictures with the camera or we're looking with our own eye. Remember, our eye is a camera itself. So if the cornea is foggy, if I were looking in with my own eye, I would have the same fog that I would have if I'm looking with a camera system. So we want to make sure that we can get things as focused as possible. Another helpful thing is being able to change your intensities and your gain. Gain on the ICON system is almost like black light correction. We can illuminate a photo without having to put any more light in the eye. So I can keep my intensity the same, but I can brighten this up by changing the gain. It's so important to know that no two eyes are the exact same. So we'll see an intensity here of 49 and a gain of 8. And I really think this is a beautiful image. We have really good focus, clarity, and saturation. But if I look at another photo, here my intensity is actually 24. It's lowered quite a bit, but I still have a lot of reflectivity in this eye. Sometimes that's just because of the way the eye is in these small babies and small infants. I still think this is a lovely image because I can see the vasculature. We have really good focus. I can see the vessels and whether or not they're starting to get tortuous or curvy. I can see that everything is looking smooth, and I know that I can make good decisions on presence or absence of disease in this point. Looking at another example, here the gain we bumped up to 10, and we can see this image getting a little bit brighter, and the intensity is at 26. I love having the ability to see these numbers, and this is where Vic and I are so happy to help. Because when I see these numbers, if someone sends me this image and says, what can I do better? We can guide them to say, let's try and drop this gain down to 6. These are usable images, very, very good images, but we could improve them a little by using some of the tools available to us like focus and gain and intensity. And here's one more example. Now we have the gain at 8, so it was actually lowered, but our intensity went up. So we still have some of that reflectivity. But again, when we're working on patients where our cooperation is in milliseconds, these are still very, very good and very usable images. There's rarely a time when capturing an image has no value whatsoever. Here's another example of real life situations where we're looking at different parts of the eye and we say, well, what does it look like to have disease and what does it look like to not have disease? Of course, an ophthalmologist or a medical doctor is going to make that decision, but just based on my knowledge, I can tell you when we see these vessels that look straight, right? We've got good branches, nothing is getting really curvy like a dam has been blocked up. We're typically saying that we have good growth. We're not going to take them off of our regimen to watch for ROP, but we know that there's nothing super alarming happening yet. We may still have some blood vessels that grow as the eye itself continues to grow, but everything looks like it's doing well at this time. In this eye, we can see a very distinct line called a demarcation line. This is avascular retina versus vascular retina. This is a very clear black and white on where vessels started and where they stopped. And then at some point, the body panicked and said, oh my gosh, I forgot to grow retina vessels. I'm just going to grow as many as I can. And they're not good. They're not good vessels. So they start to grow up into different parts of the eye. We'll see that they could leak processes here, leak fluid, and now we start to see that curviness, right? We start to see all these vessels growing in places that they shouldn't be growing. We talk about imaging different pathologies. So this is just a quick example of what we look like if we're moving from an ROP thought process into an abusive head trauma process. And what I really want to bring to the table just in this slide is showing that same thought process and quality. Right, we're trying to document presence or absence of disease. We're looking at the quality of these images and the quality of patient that I have and saying the information that I'm getting from these photos is so valuable and so important. As Vic mentioned, as I close my portion of this presentation, I want to recap Vic's discussion on our CARES kit. We really want to ensure that everyone has access to information that is at the level that they need information. So we have things that are basic, we have things that are more in depth, and we're constantly wanting to improve that. So always feel free to reach out to us. We want to make sure that you have the information that you need available to you. And we are always happy to put together educational material that helps our fellow imagers there in the market worldwide. So I will close my presentation with that slide.
Great, thank you so much, Candice. That was very captivating, very informative. I appreciate your time. I just want to remind everyone that please continue to submit your questions on the chat, and then we'll get through as many of those as we can at the end of this webinar. So now it's my very great pleasure to introduce our next speaker. Let me introduce you to Adita Lytle. Adita received her BSN from Arizona State University and began her career in the NICU. She was a bedside RN for 12 years and then moved into a leadership role as ROP clinical manager and coordinator. Now, as this was a brand new role, Adita worked closely with her senior nursing and ophthalmology colleagues to develop the protocols for nurse-led ROP screening, and this was the first of its kind in the unit where she worked. She then went on to train a team of 14 RN screening specialists, and the program successfully screened over 500 patients, which is just incredible. I know that Adita has a tremendous passion for helping nurses to learn how to be successful at retinal imaging, as well as assisting peers in creating effective ROP screening programs to meet their specific facility needs. So without further ado, Adita, I'm going to pass over to you. Thank you so much.
Excellent. Thank you, Vic, for that warm and kind introduction. I'm going to go ahead and share my screen here and turn my camera off so that's not distracting. Excellent. Okay, so as Vic mentioned, I had a very active role in setting up a very large ROP screening program. It was the first of its kind in the United States. We covered 4 very large volume NICUs, and it was very typical for us to screen over 500 patients annually. So I love helping others set up a program that's successful, and we're going to kind of talk a little bit about the benefits of a nurse-led ROP screening program, as well as kind of tools to help you get started and how to set up your program. So let's dive in. So as I discussed, here are our objectives that we're going to go over. We're going to talk a little bit about the benefits. We're going to look at the nursing perspective, the patient perspective, and the unit perspective, how to create a new program, what supplies you need, how to create your team, how to roll out your program, and then how do you evaluate if you're being successful. So why choose a nurse-led ROP screening program? I have such a passion about this, and as many of you can see, throughout the world, there's just a shortage of ophthalmologists that are qualified and that are able and willing to screen babies for ROP. And that being said, there's more and more babies that are being born earlier and earlier. We're able to, through the use of wonderful technology, we're able to help them survive. And so we're having more and more babies that do need ROP screening. So let's chat about that a little bit. So as there's a shortage of those ophthalmologists, nurses are available in all these units. And so why not implement these programs where the nurses are the feet on the ground and they're able to provide screening for these patients and send it virtually to screening ophthalmologists, and that way they can cover many, many more babies and help to provide ROP screening in very remote areas. So there's several benefits to using a nurse-led ROP screening program, and we're going to kind of break this down into the nursing perspective, the patient perspective, and the unit perspective. And you'll kind of see that they do overlap actually quite a bit, and that's on purpose. So let's get into that. So from the nursing perspective, it does give nurses autonomy to perform these screenings when they're available. It's another reason for them to get involved in the unit, and it really helps them to take pride in what they're performing in these screening exams. It helps them to gain a new skill set, and with that, it provides an opportunity for growth. Sometimes people in different units are looking for what they can put on their resumes or what they can bring to their manager of why their qualifications continue to build and why they should be maybe considered for a promotion or a raise or things like that. So it's another thing for them to have on their resume. Also, nurses are so experienced with, their NICU babies, and they're very protective of their NICU babies. And so doing these exams, they really have a lot of control of the patient experience. They can provide those comfort measures and really understand the patient cues that occur during these exams. And so they can tailor those exams to really meet the needs of each individual patient, depending on what their situation is with their family involvement. Maybe their family can only come one time during the day. And so that's not when we're going to do the exam, right? We're going to do it on a time where it's not interrupting any of our family time. If the patient is on different ventilator support, they can work around that and use their resources to really help them and able to continue to image the patient no matter what the patient's circumstance might be. And also, because you're building this team of nurses that can screen these babies, there is a consistency of care. It's always the same team of imagers that are coming to the bedside to screen the baby. And again, they're becoming more and more familiar with that patient individually. And it provides another opportunity to work as a team, and not only to involve the nurses, but you're really creating those wonderful communication lines between not only the neonatology staff, but ophthalmology staff and any other disciplines that are involved with that patient's care. From the patient perspective, let's look at the benefits from that perspective. So again, there's a consistency of the same ROP screeners coming to the bedside to perform these exams. So you do have a wonderful opportunity to build those bonds and those relationships with those families, because it's the same group coming week after week to screen their babies. Again, they're from the patient perspective, we're able to be flexible to meet the patient care needs. If the patient has a procedure off the unit, we can do it prior to the procedure or after the procedure. Or as I mentioned, if the parents are only able to come at one time and they wish not to watch the exam, we can offer them uninterrupted family time and come back and do the screening later. It also decreases their disruption of the care so that patients can sleep. And we all know how important sleep is for these babies so that they continue to grow and improve. Promotes family-centered care. As I mentioned, we're not interrupting that precious family time. We the nurses are able to utilize their skills and resources to really minimize that patient discomfort and provide them with swaddling or medication that they might need prior to. Because we're working so closely with the family, we're really increasing the parent understanding of what's going on with their specific baby. Now, in the NICU, there are so many things going on with each patient. And so if a patient does have ROP, it's wonderful to be able to show them the images on the device and show them this is what your baby looked like last week, and this is what your baby looks like today, and this is why we're continuing to monitor. And it's wonderful, especially when the disease is progressing, to get them involved, get them understand what's going on. And it really helps as they're discharged to increase that compliance post-discharge, and then help them to continue to get to those ophthalmology appointments after they're no longer in the hospital. And another patient benefit is that because the nurses can provide ROP screening in more rural settings, the patients can stay where they were delivered. And it decreases the patient transfer, and therefore we're not separating families from the facility that they chose to deliver in. And there are, of course, benefits from the unit perspective as well. So units love to be known for their family-centered care model. And so this is another way that we can support that model and really provide a secure environment and a comfortable environment for those families to feel like they're involved in their patient care, which only leads to better scores and just better word of mouth referrals, even for delivery centers, if they had a great experience there. We're going to decrease the missed patients because the nurses that are there on the site are making sure that the patients fit into the screening schedule when it's appropriate for them. And if the patient happens to be transferred or moved to a different unit, the nurses are aware of that and make sure that they're being followed by ophthalmology as needed. Also, it helps to keep revenue within that patient or within the hospital itself, because we're not transferring patients out, so they can keep that revenue that they're getting from those admissions. The ophthalmologist doesn't need to physically access the unit as frequently. They're able to remotely view the images for their ROP patients, and then able to spend more time seeing their own patients within the clinic. So that's wonderful. And it also provides, and this is a huge thing in the United States, it might not be pertinent in other areas, but in the United States, it provides the autonomy for the unit to continue to provide the ROP care, again, so that it prevents transfers of patients, and that helps them to maintain their level 3 NICU accreditation. Also, from a unit perspective, when you're having this nurse-led ROP program, it really does increase communication within the care team, because you have someone that's very involved and invested in making sure that the baby is getting the care that they need from an eye perspective. And so it just helps unite everyone from the neonatology standpoint, from the ophthalmology standpoint, nursing, and then any additional therapies that might be involved with the baby. And it helps to provide a seamless discharge, that all those outpatient appointments are being created in a timely manner and an appropriate manner. Okay, so your unit has decided you're going to go towards this ROP, the nurse-led ROP screening program, which is so fantastic. So, but you might be feeling a little bit lost and a little bit nervous, and where in the world do you start? So let's talk about what those next steps might be. So in my particular circumstance, I was identified as the ROP coordinator. So I was the lead of the program. And I do feel like that is a very important role to identify very early on in your program creation, so that this person can be involved in all the steps, but also it just creates more of a passion and more of an involvement and of an awareness of what the needs are. And that way you can really tailor your program to your unit and your facility needs. So after you've identified your ROP coordinator, you're going to want to select your ROP team. And then after that, you're going to want to establish protocols and workflows that are going to be appropriate for your unit. You're going to establish how you're going to train your staff and how education will be provided, not only for the staff, but for parents. And then you're also going to roll out your new program. So again, we're going to want to select the best team possible. Your first person that you're going to select is your ROP coordinator, then your screeners. You're also going to want to identify your reading ophthalmologist as well as your treating ophthalmologist, or how infants that are identified that do have ROP or ROP that's progressing towards treatment need to be treated. So that is a workflow that you'll definitely want to identify. And then, of course, how your neonatologists and your practitioners are going to be aware and notified of what's going on in the eye with these patients. So here's some characteristics that you should be looking for when you're creating your team. You want someone that's comfortable with the eye. So the eye and eye exams are not everyone's cup of tea. And so you want to make sure that it's someone that is comfortable with eye exams. You want to make sure that your team has excellent communication skills, that they're motivated, that they're willing to learn. It is a new skill that they're going to need to learn. And so you're going to want them to be willing to put in the time, put in the effort, and be excited for it, right? You also want to find people that are very cognizant of all the details surrounding the patient, that they have great attention to detail, that they're comfortable with technology because they are, of course, going to be using a retinal camera, that they're reliable, that they show up for their shifts, that they're engaged, and that they're that they'll be there when they need to for these screenings. You also want someone that's highly organized, that is excited for the change, and that works well in a team and is ready to get started in all of this. So as I mentioned before, your ROP coordinator should be selected first, and that should be either a nurse or a nurse practitioner. And that's the person that's really going to be involved in overseeing the schedule and when patients are seen, and making sure that they're seen in a timely and an appropriate manner. So how many screeners do you think you need? Well, this is a kind of a challenging question to answer. So it's really based on your facility need. As Vic mentioned, my team ended up having 14 ROP screeners, but that was spaced over 4 different facilities. So I always recommend that you start with a minimum of 2 to cover your vacation and sick days. So if your unit is screening more babies, you can absolutely add to it, but I wouldn't start out training too many nurses, because you want it to be a skill that they can really hone in on, that they can practice, and that they can be really skilled at while still providing your unit and the patients the coverage that they need. So when you're selecting your screeners, you do want to make sure that it is someone who is experienced in the unit that you're in. So if you're in the NICU, you want someone that has been there for at least a couple of years, that is familiar with how the unit runs, how the processes flow in the unit, and that they're comfortable taking care of patients. Because when they do go to screen the patients, there are going to be a variety of circumstances that the patient might be experiencing that they need to be comfortable approaching and performing the screening. Okay, so you've selected your team. So the other thing to think about is, where do you go from here as far as your protocols and workflows? So in the United States, we use the American Academy of Pediatrics ROP screening recommendations as a baseline for all of our protocols. So when I started my position as ROP program manager, we had nothing in place. So we were going from a program in which the ophthalmologist would come weekly and do bedside exams with a binocular and direct ophthalmoscope, and he would do them in person. And so we were shifting from that type of program to a nurse-led ROP program, and we didn't have anything in place for protocols and workflows. So we really had to start from scratch. We started with the Academy of Pediatrics ROP screening recommendations and kind of used that as a framework and built around that for our protocols. But I also recommend, if you're in a facility where locally, wherever you are globally, if there are other ROP screening programs, you may want to reach out to them and see kind of how they work their programs and what they recommend. So whether that's local to you or in other nearby countries. What's fantastic about Neolight, which I wish I had when I was starting my program, was that they have this wonderful CARES kit that Vic and Candace talked about, which is so incredible because it provides a framework for so many things, but especially for workflows and protocols and procedures. So you're not having to start from scratch. You can take it and you can adapt it and you can tweak it however you need to fit your facility and your country's standards, but you're not having to start from scratch, which is so incredible. The other thing you're going to want to identify is on what day does your ophthalmologist want to read these exams. So that's going to dictate when you're going to do the exams, right? So you want to identify, does the ophthalmologist want to read them first thing in the morning? So do they need to be done on night shift? Or is your ophthalmologist going to read them after clinic hours or during their break midday? So that will definitely dictate when you're going to be performing your exams. And then you're also going to want to work closely with your IT department, because you're going to want to identify how those images will be transferred to a situation where your ophthalmologist can read them remotely. Okay, so what are the supplies that you need? So of course, you're going to need a retinal camera. So this is a picture of the ICON. You're going to want to use a coupling gel. The gel is going to create a nice bridge from your lens of your camera to the image that you're taking of the retina, and it's going to provide a better way for you to see out into the periphery. It is a nice viscous coupling gel. This is one that we recommend, but you can definitely reach out to Candace or Vic or and find what ointments or gel is available in your area. You're going to want to have speculums of various sizes, and we're going to go over that in just here in a little bit. And then comfort measures for your babies. So not every baby is able to have sucrose or a pacifier, but if they are, those are wonderful tools to have on hand. You'll also want to have some gauze and some sterile water for cleanup. And then, of course, comfort measures. They're so important when you're doing these exams. I always recommend a second pair of hands. I never recommend screening on your own for neonates because they are wiggly. And so you want a second pair of hands for containment. Honestly, sometimes even a third or fourth pair of hands, depending on what the patient's circumstance is and how squirmy the patient is. You could also want to consider any swaddling or containment devices that you might have on the unit. Okay, so let's consider speculums. So these are some of the speculums that I used during my program, but depending on where you're located and what where you're getting your supplies from, they might be different, but this is kind of what they look like. They range in sizes, so you're going to want to have various sizes. So I always recommend at least 2 sizes, but if you can have 3, that's wonderful. Some are a little bit larger, some are like a medium size, and some are smaller. So you want to make sure that you have the right size for your baby, because if you don't, what's going to happen is if the speculum is too large, it's going to prevent contact of the lens of the camera and the actual lens of the eye. Same thing if it's too small. You're not going to get your speculum to open the lid enough, and you're not going to be able to get those images of the back of the eye because you're going to have issues with contact. So those are really important tools to have on hand, and a variety, as I mentioned. Another thing to consider is perhaps using a scleral depressor. This is the Flynn lens loop depressor, which I used and I liked, but that's of course up to you guys of what you feel comfortable with, and also what your ophthalmologist is comfortable with you using to move the eye. So when you're setting up your program, you want to train your nurses, and practice makes perfect. The more you can get your hands on that device and practice your body mechanics and how it might be oriented for different patient situations and different bedsides at your facility, it really makes a world of difference. Most devices come with a false head and a false eye so that you can practice measuring that way, or imaging that way. And I always recommend getting as many practice sessions in as possible before you transfer to live patients. I always recommend starting to image with 2 people. Well, I always recommend imaging with 2 people regardless, but especially when you're starting out, making sure that you have 2 people available is wonderful. And then you're going to want to set up a process for how you're going to competency validate your nurses. And the CARES kit, again, is an amazing tool that actually has some examples of what you can use for competency validation for your nurses, whether that's yearly or biannually. And then what's another great tool that you should utilize is the train the trainer approach. So you're going to train one person, perhaps your ROP coordinator, to be the the expert, right? And then as if nurses leave or they come and go, or your program is doing well and you need to expand because you're imaging more and more babies, they can pass on those skills to new incoming imagers. Okay, so you've got your program in place, you're ready to roll it out. I think the most important part about rolling out a new program is communication. So you want to communicate with your staff that's there so that they're aware of this change and process that's occurring. And then you also want to educate those parents. So you're going to have parents that are there that perhaps had babies there when you still had your old program in place or whatever that workflow looked like. So you're going to want to make them aware that a change is occurring and what they can expect and how it's going to impact the care of their baby and all that good stuff. So you might want to create a parent handout. That's what we did, that we provided to patients and that were already in the hospital. And we provided them with a handout that they knew what to expect, as well as another handout for future admissions that was included with our admission packet, so that going forward, when patients were admitted, they understood what ROP was and what the process was of following for that. And then as your program is rolled out, you're going to modify and make adjustments. It's never going to be perfect on the first try, but you just need to be flexible and kind of roll with the punches. And then again, ensure that your whole care team is on board and that they understand what's going to go on in the changer process. So you're up and running. What are you going to do to make sure you're successful? Well, you're going to want to make sure you're really diligent in observing and evaluating if there are any missed patients. That's key. You want to make sure that whatever changes you're doing to your program, that no patients fall through those cracks and that they're being screened in a timely and appropriate manner. You're also want to talk about the quality of your imaging. So as I mentioned before, practice makes perfect. The more you can get your hands on the device and practice on a false eye, the better you're going to be when it comes to getting on actual patients. And then it's wonderful to be able to ask for and obtain support and feedback from your reading ophthalmologist so that you gain confidence and your images can only improve from there. Also, another key thing to continue the success of your program is to provide continued education for RN screeners. It'll keep them motivated, keep them happy, keep them understanding of how they can become better imagers. And this is just something that's wonderful to provide. And then any adjustments in workflow, you'll want to make sure that those are being addressed and implemented. And then, of course, outpatient follow-up. Once the babies are discharged from your unit, you want to make sure that there is an outpatient follow-up program in place and that they're not being lost to follow-up. I know this can seem daunting, especially when you're changing from a more hands-off approach to a very much so nurse-directed, nurse-led ROP screening program. I know it can be a little bit scary, but they have been so successful worldwide. I know you can do it. There's so much support out there. I really encourage you to use those resources. And Neolight is so wonderful. Their clinical education team is really great at providing you those resources and do the support that you need, especially when you're first starting out, but the whole time while you're doing your program. So thank you for listening. And that is my presentation.
That's wonderful. Thank you so much, Aditya. I just wanted to raise a point that you mentioned at the start of your presentation was really the challenges that that the nurses face with the availability of pediatric ophthalmologists, and that's a global issue. We know that that's a global issue, yes. And so your encouragement, your feedback, and your kind of I guess sharing your experiences is really valuable to those people who are listening into our presentation today. So thank you to Aditya and Candice, both of you, for your valuable contribution today. Thank you so much.
Thank you.
Thank you, Vic.
Now, it's my very great pleasure to introduce our last guest speaker, Julie Flanagan. Unfortunately, Julie could not be with us due to her clinical responsibilities, but she was very gracious enough to record an interview with me just last week. So let me introduce Julie to you. So Julie Flanagan is a registered nurse. She's a registered midwife and independent nurse prescriber. And she currently works as a senior sister and ROP screening coordinator at the Newborn Intensive Care Unit at St. Mary's Hospital, in Manchester, UK. Julie comes with over 20 years of clinical experience, and she started her screening journey just over 10 years ago. She was a pioneer in actual fact in being one of the first to step forward as a nurse screener, and then has since gone on to develop an amazing service with the help and support of the pediatric ophthalmologist there, Professor Biswas. Now, Judy went on to develop a retinal imaging course consisting of competency-based education and training, which has been accepted by the Manchester Foundation Trust NEST portfolio. NEST, I believe, stands for Neonatal Education Training. And Judy is also a member of the UK ROP Guideline Development Group, which is responsible for ROP screening treatment updates. So I'm going to hand over to Judy.
I really had to sort of develop it myself. And in actual fact, the initial sort of education program I took from a gynae education program.
Right.
So it was nothing to do with ophthalmology. So
that's incredible. Yeah.
So basically it was a competency-based document that I did in the first instance, just following through the whole screen, how we would screen, where we would start, using the speculum, all those simple, the whole screening process. I just looked at the whole screening process and then broke it down into parts. And then that's how I developed the competency document alongside. I mean, Mr. Biswas would have been quite happy for me to just see one, do one, but I wasn't happy because it was such a different skill set.
Of course.
I did find it challenging because as a nurse, you're obviously doing a different, your role is different. And then to actually look at baby's eyes and have absolutely focus on that baby's eyes, it can be quite difficult to take that transition. And that's took a while to develop because you are the nurse. So, but then you know all about comfort care measures, you know all about pain and signs of pain. So that's why we went down the nursing route. And obviously I was here as well all the time. So I could look at the babies, where the pathways, what they were on, when it was the right time to be able to screen them, where often it would, a baby on a Thursday, which is when we do the clinics, that baby might not be well. So that baby would miss the screening, and it's a very timely condition that we have to get right. So we found it very valuable to be able to have a degree of flexibility within the service to screen the babies when it's right for them, and not. I mean, you have to take into account the guidelines, the ROP guidelines. You can't just do a baby 3 weeks before because you think in 3 weeks it's going to, it's something else is going to happen. But you might know that the baby's going down to scan for an image or something like that. So you don't want to be doing an ROP on those babies then. You might fit that in the next day and things like that. So it's been a valuable tool, an absolutely valuable tool, and allows the service a degree of flexibility. To be able to fit in with the baby's pathways. So it's very, very rare that we don't miss babies. We haven't missed babies. The only reason we might not be able to undertake a screen is because the babies are too clinically unwell.
Right. Yeah. And you said something very important there, and I know that people will have picked up on it, but it's the statement that you mentioned about the fact is that you're there. You know your patients and you understand your patients. You understand, what they need and when is the best time to screen them. Because sometimes they might not be ready for screening when the ophthalmologist is ready to screen them. So that's something that I know will resonate with a lot of the people that are hopping onto this webinar, but generally also people who are thinking about setting up a system as well. So from your experience, from 10 years ago right up to today, now I know that you've trained, you and I've spoken before, and I know that you've trained other nurses. How did that come about, and how do you kind of go about selecting people that are the right kind of candidates for becoming nurse imagers?
So I don't think you can just sort of grab somebody off the unit and say, right, you're going to be a nurse imager. There has to be passion about, and there has to be an interest in what they're doing, because that's the way you get the best performance. That's the way you get the right sort of people. So we've recruited onto the team. Obviously, you have to look at forward planning as well. You know, people leave, and then you've got to then train other people to become imaging nurses. And it's usually the people that have an interest in ROP, have shown motivation and have shown that interest in that area of practice that we tend to recruit to. Because they're the people that we're going to retain. They're the people that are going to get the most out of the course. And they're the people that are going to enjoy the taking the images and educating the staff and educating the doctors, because it's been invaluable for being able to educate the new staff coming in and the new doctors coming in, and also for the parents to be able to engage with the parents more, and get them to understand the involvement that they need to participate in their baby's care, and understand what it involves about doing the imaging, and what why we're seeing babies weekly, why we're seeing other babies 2 weekly, and what are the concerns. So, and it's having that passion, having the champions to promote the ROP, because unfortunately ROP screening has got a degree of negativity because of the associated possible side effects. It's not a procedure to be taken lightly, Vic, you know what I mean? We are finding that we have less detrimental effects with imaging because you're not using the indenter. We do use the speculum, so you still need the dilation drops, but you're, because of the field of view that you are achieving, you're not having to use the indenter, and you're learning tricks and tips on how to optimize that view. There's lots of studies that has been saying that imaging is less invasive is more sensitive to the baby's needs than maybe an ophthalmologist coming along using indenter, where they might cause some corneal bruising, because they're that enthusiastic trying to get the area that they want to see. And often we've had babies coming over, and the diagram that the ophthalmologist has done is nothing like what you're actually seeing with the imaging device, because it's like a jigsaw. They're trying to draw everything together, where the imaging device is live. Do you know what I mean? You're actually seeing that ROP, and the fact that you can do a comparison it is just so amazing, that you can see how the pathology is changing week by week. I'm very passionate about it, and I want people who are also passionate to do it, because that leads to a better success of completing the course.
Definitely. And I've spoken to you a few times, and I can definitely see that passion, and I always kind of leave our conversations feeling really enthusiastic about learning more about ROP and screening. And for somebody that's at the start of their journey, then Julie, someone that's thinking about becoming an imager, what's the one piece of advice that you'd give them that wish that you'd been given?
I think to be patient and don't put too much on yourself. It's a completely different skill set. It's a completely different area of practice. And I think you just need to be patient to be able to, you need to have a lot of information about the pathology, etc. And it's a learning curve, and it's a steep learning curve. But at the end of it, it's a fantastic experience to be able to undertake these images and to be able to manage this condition in such a timely manner, and work as a team with the ophthalmologist, and work as a team with the parents, and engage in that to be able to manage ROP effectively. And when you get a baby who comes back in, who's had treatment, and comes back in, and the parents are just value so much the input that you've given, and it educates them as well. It's just such a fantastic thing to do at the end of it. Steep learning curve, but when you get to the end of it, it's an absolutely valuable skill to have.
Yeah, absolutely. Okay, so For somebody that's maybe thinking of setting up a system, a screening program, I should say, what are the key must-haves, would you say?
Well, you have to have investment from the management, from the higher management who see, and an investment from the ophthalmology team.
Yeah.
Because ultimately, without them, they are the graders and they ultimately manage the disease. We do the nurse-led screening, and I might be able to say to Mr. Biswell, this baby needs treatment, but ultimately it is his decision as to whether that baby requires treatment or not. Obviously, it's to have experience with ROP, having a bit of knowledge about ROP, to be able to have the equipment that is required, which is like the eye sets, being aware of the effects of the drops and the type of drops that you need. I mean, imaging is fantastic, but without a dilated pupil, Vic, you're not going to get adequate images. So you need to have an awareness about the positives about imaging, but also the restrictions with any method of screening. You know, the bio has got some negativities as well as some positivities, and being aware of that, really. And we do a mixed strategy for babies. So we do the majority of their screening is done with imaging, but the final review, because of the criteria for discharging on ROP screening, is to get out to zone 3. And even though we may be able to get out to peripheral zone 2 and maybe into anterior zone 3, there's no way we can get into peripheral zone 3. So the final review is a binocular indirect ophthalmoscopy. So you have to have the team engagement with that to be able to do a successful strategy. But I know that some units London solely does imaging and discharges on imaging. And I think that's the way forward. That is the way that we will go once people have more confidence with imaging and the capabilities of the imaging and the technology that's moving on all the time. So it's just having the right equipment, the dedication of the workforce, the technology to be able to store that data and share that data with the right people, and having somebody who having the same team that are as passionate as yourself, really, to be able to do it.
Yeah. What does what are the key criterias, would you say, for training? You know, obviously that enthusiasm and the passion is really important, you know, to be engaged in the whole process. But what from the training program that you've been rolling out, what are the key things that people maybe need to be mindful of if they're in the same position of thinking about doing something similar?
It's quite a commitment. But because our course is actually 4 to 6 months, but we're hoping to shorten that. That's because we do weekly exposure. But if somebody was going to be doing it all day, then obviously that would condense the course. Having said that, it can be quite challenging, you know, taxing on the brain to take that amount of information in all in one go. But it has been done. You know, we know that that has been done. So we have an education platform so that they get a background and a foundation knowledge about ROP. They might have had some experience of the pathways, maybe helping a doctor to do a binocular indirect ophthalmoscopy review, but they don't really understand all about ROP and awareness of the classification, etc. So that sets up that they need to understand, because when you're taking an image, you'll be like, what's that? I don't know what that is. I don't know. You know, having a basic awareness of the eye, about the optic nerve, about the macula, about what are retinal vessels and the layers of the retina and things like that. So all those help to improve your the process of imaging, and then the effects of the actual screening process on the infant, not just about comfort care measures, about pain, pain relief or pain scores, how the baby's handling the screen, when you can screen and when's the right time, about feeding and how much that can impact on on the baby actually having the screen, and then the technology and awareness of what the machine does. And that is quite imperative, really, because of how much we do a lot of teaching on the technology, familiarization with the device, certain functions that the device has. I mean, at the moment we still do still images, but obviously you can do, if the baby's really, really getting agitated, you can actually go on to doing a video, because that takes less time, but you can still slice into those images and take that information from there. So, but you need to establish your skills before you could move on to doing videoing, but that is something that we're considering and looking at and things like that. So, and involvement of the parents in the decision-making process, the involvement of the multidisciplinary team in the decision-making process, because they have to look after the babies after the screen, which the baby may have some side effects, bradycardias, the fact that they can get feed-induced bradycardias from the drops because of the slowing of the gut. So all those things you need to take into account, as well as patient identification, Vic, ensuring that you've got the right patient. How will you store these images? How will you protect that patient data?
Yes.
We've found a lot of that as time's gone on. How will you contact if the ophthalmologist is remote? How to plan the clinic? What type of babies will you screen? Are some babies better being left for the ophthalmologist because of the fact that it's a discharge review, and so that baby could be done in another day? But then you have to look at what the pathways the baby's already on. So that's how we've done it, really. And then at the end we do a competency assessment. So you might have an interim assessment a month or two into it when you're starting to do some images. We use a simulation doll to get people used to just handling the camera, and how by just keeping the camera on the eye, you just tilt. You only have to tilt. You don't have to move the camera to get to get the images, and not to worry about the medical terminology like temporal and nasal. Just think, where's the optic nerve? The location of the optic nerve tells you if it's I use a clock face. I don't know whether, I'm sure my colleagues in other countries will do it differently, but I use a clock face. So 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. Those are the images that you need to get. And then obviously the central image of the optic disc. And then you want to make sure that the baby's dilated. So you would take a picture of the front of the eye or the anterior segment to make sure the baby's dilated. So
fantastic.
Going into all that as well.
Great.
So there's a lot of
Thank
information, but all that information makes you a better imager.
Yeah, absolutely. And I think when we spoke before as well, you said that kind of the assessment or the criteria to make sure that you're up to speed is done on an annual basis on your unit. Is that right?
Yes, it's a self-assessment.
Yeah.
So all the people that are working on the unit and anybody that we've taught, because we've taught some external candidates as well, we're always open to them saying, I'm struggling a bit. I've not looked after babies who are very dark. I haven't done any images on a very dark baby. Can you give me some tips and tricks? Where you can do a Teams meeting, or they can come over to the unit. And provided they have some sort of contract, they can come over to your unit and become exposed to those type of things. Talking about the capabilities of the device, on what you have to do to be able to optimize that view. So that's the type of thing that we tend to do. But they do a self-assessment, and that's worked on a competency-based document. And we also have a guideline. So that looks at your scope of practice, what babies you can screen. These people the people that work here work on the neonatal unit. If a baby needs to be screened on a paediatric unit, they shouldn't be going down to the paediatric unit to screen that baby because of the information governance framework that they're working on. So they can go down and assist the ophthalmologists, but the scope of practice is the recognition of your scope of practice is crucial, because if anything happens to that baby down on paediatric unit, then you're the accountable person.
Yeah, of course. Yeah, that makes sense. We've lost your video feed, but we'll just carry on. You mentioned if you've got patients with dark fundi, what are your kind of hints and tips on imaging darkly pigmented infants?
Okay. So from an intensity perspective, you may have to go slightly up. I mean, I know you can preset on the particular device that we have. You can do preset, but we don't do that because people are training, and we want them to see and be exposed to the difference that using the intensity and gain to complement each other to be able to get better images and clearer images. So we tend to go up on the gain rather than on the intensity. You might go up by 1 or 2 points with a baby who's got dark irids, dark eyes, but not significantly. We certainly wouldn't go, because that white light intensity can be really uncomfortable for the baby, and then you'll obviously get a non-compliant baby that can cause quite a bit of discomfort. So you would use the gain, but you know that if you go too high on the gain, then it can the images can become very grainy. So we tend to go up maybe onto a level of about 20 on the gain, maybe not much more than that. But you do a test. You're testing that all the time while you're doing the images, and maybe the intensity I would only go up to maybe 10.
Yeah.
On the dark babies, and go up on your gain a little bit. For the front of the eye, when you're looking at a condition called tunica vasculotis lentis, which is where you see iris vessel engorgement, you may go up a little bit more on the gain just to pick up those fronds of vessels. But then you would come back on the gain to actually take pictures of the fundus itself. Yeah. So, and we found that works for us, Vic. That does work for us. So
that's excellent. And really, it sounds like it's more of as you're developing and honing your skills, you kind of learn then in terms of how to manage the device and the settings depending on what the patient requires at the time.
Or previous images. You look at previous images. Look at how clear those images are, and take those settings to the next the next screening session as well. Yeah.
Absolutely, yeah. So you're kind of building on your experience as you go along. Perfect, excellent, great. Well, I want to extend my gratitude to Julie for sharing so much of her valuable time. What we're going to do now is we're going to open up to questions that you've been submitting. So thank you for that. Please continue to submit those questions on the chat. I don't know if my colleagues are ready to answer some of these questions. Perfect. So one of the first questions that we've had, and I'll throw this open to both Aditya and Candice, is it neonatal nurse practitioners who have to perform imaging, or can registered nurses use the camera as well?
Yeah, registered nurses can absolutely do the imaging. It needs to be someone who is at least a registered nurse. So some programs do all registered nurses. Some I've seen do a mixture of registered nurses and nurse practitioners. So it really just depends, but it wouldn't be someone, you wouldn't use like a CNA or a nursing assistant. It would need to be someone who's licensed.
Sure. Perfect. Thank you, Aditya. The next question that we've had through, so thank you so much for this one, is what's the best way to make sure nurses stay educated in terms of their goals, documents, skills, checklists, etc.? Candice, would you be happy to take this one?
Absolutely. And I know Aditya really helped with a lot of the documents that we made when we built our CARES kit. Just watching the program that she built, it kind of guided us to make documents in terms of goals documents, to say, I want to be able to read these guidelines that are specific to my territory. I want to be able to say, regardless of whether we have infants for imaging within the unit, I want to get this camera out every single week so that I'm building on that muscle memory. And of course, those documents then go into helping with the skills checklist and really making sure that we're staying fresh on those skills and then growing the skills that need to be grown.
Perfect. Thank you, Candice.
Absolutely.
Another question that's just come in. Thank you so much for that one. What are the tips for imaging micropremies, things like speculum size? That's a great question. Thank you.
That is a great question. So a very important tool to have is the correct speculum size. Is you want to make sure you have a small speculum that's appropriate for micropremies. Because if you use a speculum that's appropriate for just your standard newborn, you're really going to have a difficult time getting good contact, because the speculum is actually going to open the eye in such a way that it's going to prevent your camera actually from getting into the eye. So you want to make sure you have the appropriate size speculum. And then, of course, as I mentioned, containment and comfort measures during the exams are very important as well.
Great. Thank you, Tita. Another question. Yeah, this is a good one. Are there support groups for new programs, like user advisory boards? And that may change depending on where our listeners are coming from, people attending our webinar. So I don't know if you guys want to just comment on your personal experiences of that.
Yeah. I think within Neolight, we really try to support user advisory boards. In fact, anytime we're seeing a strong imager like Julie and like Adita, we really try to grow those relationships because from my standpoint, I have a really great background in ophthalmology, but we really need some of that nursing side to partner with our education efforts. So we're constantly building out user advisory boards, medical advisory boards, and we try to support those in different areas as well as we see different territories onboarding groups to make sure that we have those anchors, those people that we can recommend and anyone can reach out to when they're building their new programs.
Great, thanks, Candice.
Mm-hmm.
We've got so many questions. I am not sure that we're going to have time to address them all, but we will be sharing our contact details at the end of the webinar. So please do not hesitate to contact us directly. We'll be more than happy to answer your questions. Let's just do a couple more. All great questions again. What type of parent education should be provided?
I think it's important to have some kind of document that you can provide your parents so that they know kind of what to expect if their baby qualifies for an ROP exam, when that ROP exam might be, such as what date it might be on, and then maybe the time, just so that they can decide if they want to be there or not. And then some type of education providing the results, right? And kind of explaining what ROP is, kind of selecting what their baby has and what the follow-up that's recommended is. It's always great too if once you feel comfortable looking at the images and showing them from, pulling up that baby when the parents are there at the bedside and showing them from week to week what the exams look like. It really helps them to understand what's happening with their baby.
Yeah, that's a great it's a great question and a great response to Adita. I know that from my experience, having that having the parents involved right from the onset is so valuable in terms of that journey, not only for the patient but for the imager, and getting the parents engaged early on is really vital. So I 100% agree. We're hopping back onto the education side. So what type of frequency of continuing education or competency validation should be considered? That's a great question.
Adita, you want me to do that one, or you?
Oh, yeah, you can do that one.
I mean, Adita knows from the nursing side, like that we typically see these probably done either bi-yearly or yearly. And then I think I had mentioned earlier, just from a continuing education standpoint, when you're building a new program, you want to get that camera out as often as possible, and you want to practice like you play. We're always telling the new nurses, actually stick the little baby head, the test eye, put that in a radiant warmer, in an incubator, in a crib, whatever your imaging environment is, and really get used to those small details. Where do I put the system? Where do I stand? Where would my partner stand that's imaging with me? Because when you get those details down, it makes those imaging sessions so much easier. But I'll let Adita kind of speak to how often we would see those competencies revamped and rechecked.
Yeah, so competencies usually are done, as Candace mentioned, annually or biannually. I guess it depends on your facility, but I would say at least annually. And that way, too, from an accreditation standpoint, if anyone has any questions of when the nurses were last checked off on their skills, they can pull that up, and it's a document that can be easily referenced. There are some examples of that also in the Neolight Cares Kit, some skills checklists that you can use, and kind of walks you through using the system. And that way, whoever's overseeing those nurses can initial off that that yes, they can appropriately use and safely use the device on imaging patients.
Yeah, absolutely. Thank you both. And we heard in Julie's video that on her unit, it's done on an annual basis as a self-assessment, and that's, I think, for me, from my experience, that's what I've seen more often than not. There are a few places that do like a biannual assessment, but it's really down to kind of your hospital protocols and the criteria that your education requirements are. So yeah, thank you both for that. For beginning images, so I think the question is, for images at the beginning of their journey, what's the best tool to have on hand? That's a great question. Thank you for that.
I think I will say the same thing that Julie said: patience and grace. You can have all the tools available to you, but to have patience and grace, especially when I think of comparing myself to an ophthalmologist who spent many, many years training in school, and I'm coming into the new process. Patience and grace is what we need.
100% agree. Anything from you, Adita?
Yeah, I would agree, definitely. If you're looking for like a physical tool, I would definitely say multiple size speculums would be huge. Like that's what you need to have, and you have to have a good coupling gel, or you're just not going to get those good images. So those would be the two physical tools that I would say. And if you could, a second pair of hands is always recommended.
100%.
But yes, patience, understand that it takes practice. It's a new skill, and every time you do it, you're going to get a little bit better at it, and just be patient and hang in there, and you can get it. It is something that has been, as I mentioned in my presentation, it's successful worldwide. Many nurses do it. So it definitely can be done. It just takes some time and some practice.
Absolutely. Yeah. I think you're absolutely both right. Embrace the fear when you first start. I think you just have to be brave and know that, there's colleagues around the world that are already doing it, and practice makes perfect, and they have become expert imagers. So draw on that, and patience. Absolutely right. And I've spent quite a bit of time with Julie, working with her, and it really comes across. She's a real advocate of just don't be too hard on yourself. And I know Candace mentioned that in her presentation, but that really does come across, that just don't be too hard on yourself. It's you will get there, and practice makes good. So we're going to finish off with one more question. Thank you so much, everyone, for all the questions. We won't have time to get through all of them. But this is a good one to end on, I think. What's the one piece of advice you'd give to someone who's imaging for the very first time?
Oh gosh. I would say take a deep breath and maybe wear some shoes that you can take off because you might have some trouble using the foot pedal. And so if you have some shoes you can take off, that's helpful sometimes. Put a bootie on, a surgical bootie.
Yeah. Perfect. Thank you. Excellent. So I think unless my esteemed panel and colleagues have anything else to add, we're going to draw this webinar to a close. So I want to thank Adita and Candace and Julie for their valuable time and input, and also my colleagues who helped put the webinar together, and of course for all of you for attending. We're very honoured and grateful that you spent the time with us. And of course, if you have any questions, our contact details will be shared at the end of the webinar. Thank you so much. Thank you.